So good afternoon, ladies and gentlemen. That was a great session on tricuspid valve replacement. I certainly learned a lot. I hope you guys did. And thank you for joining us back at TIO 2024 for this session, reverting towards TAVI, entitled TAVI, Is Lifetime Patient Management the Alpha to Omega of Contemporary Practice? This session over the next 60 minutes is sponsored by an educational grant from Boston Scientific. So to explore this topic, we have three fantastic colleagues. We have Francesca Sanguineti from my alma mater in Massy in France, Verena Veulemans from Düsseldorf. Ladies, you definitely did better in the pictures and the introduction than David and I, so we're going to have to talk to Nicholas and get some better pictures for the boys next year. And then we're going to be joined by David Hildick-Smith for a live case for the last 30 minutes from Brighton in the United Kingdom. So welcome, guys, and thanks for spending your afternoon with us. So the topic at hand really is lifetime management, particularly as it pertains to younger patients. And maybe what we should do is open up with that case that David is going to treat later on, and we can have a look at that case and then use this case as a template on which to discuss lifetime management with Francesca and Verena. So let's have the slides up for David's case. David is a minimalist in many ways, and so we have some minimalist slides from David. So let me see if I can advance these guys. If I refresh this. Here we go. So it's a 76-year-old lady. She presents with NYHA Class 2 dyspnea on exertion over the last number of months. Her echocardiogram demonstrates normal LV function with a peak-to-peak gradient of 65 and a mean gradient on echo, as David has suggested there, of 65 millimeters of mercury. So diagnosis of severe symptomatic aortic stenosis is made. Next slide, please. The CT scan, we don't have the entire scan available, but David's going to take us through some more of those details. But this patient really has quite limited aortic valve calcification, as you'll see from the moving image in the next slide. The total calcium score is only 650 Hounsfield units, so moderate calcification at best. And as that scan comes into view, you'll see that it's really on the non-coronary cusp where the calcium is. The left and the right coronary cusp don't have a lot in the way of calcium, certainly towards the middle and tips of the leaflets. The dimensions of the valve render this a relatively small anatomy with a perimeter of, I think it's 68 millimeters, an area of 367, maximum and minimal diameters of 24 and 19. So a relatively small anatomy for this young patient. The femoral anatomy is not particularly challenging, no significant tortuosity, large diameters, and so one would not expect with contemporary TAVI to find any significant challenges in terms of transfemoral access here. The patient, as far as I'm aware, has been randomized in the BHF Protect TAVI study. This is an important study looking at the efficacy of the Boston Scientific Sentinel device at reducing periprocedural stroke. But also interesting to see that this aortic root is relatively angulated, and maybe that would affect prosthesis choice in this patient. We're going to see David and his team will probably explain this slide to us, but they're planning femoral access as discussed, a secondary arterial access via the radial, ProStar pre-closure. So an interesting blast from the past there. David can show us the steps in ProStar use for those that haven't used it in a decade. As I mentioned, the patient is randomized in the BHF Protect study, and the plan is to predilate with a 20 millimeter balloon and implant an accurate Neo 2 small valve and closure. So maybe what we might do is have a quick discussion amongst ourselves, Francesca and Verena, regarding this particular patient. Francesca, can we use any device here? Balloon expandable, self-expandable, does it matter with a patient like this?
Yes, I'm going to speak about it in a few seconds. So I don't want to share immediately all my details, but I think no, in this case, no, because we are dealing with a young patient with a small annulus. We have the chance to do not have a lot of calcifications. So this is a good point, but just let's talk of this concept of young patient. We don't want to have a bad hemodynamic results. So maybe I would orient my choice with the supraannular valve, but we have also to deal with coronary access. And we know that supraannular valve are going to the classical one. I mean, like Evolut can be a problem in this way. I don't know that you didn't mention, but maybe we can discuss with David the coronary high. So I don't know if we'd have enough place, but this is an important aspect, I think, to consider too for the choice of the prosthesis. So not for me, every prosthesis is the good one for this case.
So Verena, Francesca tells us that coronary access is important, hemodynamics are important. What other issues would be would help you in terms of valve choice for this particular patient? We can get a good acute result with any valve system here. But what about that longer lifetime management?
Yeah, I guess Francesca already mentioned the most important points. Also, the acute outcomes, including hemodynamics, are also the choice. The supraannular design in this patient, which provides a larger effective orifice area, which also prevents patient prosthesis mismatch, which can affect also the long-term results and durability of the patient. In this special patient, it is also important that he has, it looked like something like a horizontal anatomy, and therefore this device is also very good because it has this flexibility of the delivery system and the top down deployment.
So a little bit more stable and maybe when there's less calcium. So certainly we feel that most systems would be suitable in this patient, but maybe there are specific situations whereby the Neo2 can be beneficial, such as that horizontal annulus, coronary access, and good hemodynamics. So Francesca, maybe we'll ask you to open up and give us your thoughts on what are the important aspects of lifetime management for younger patients, and maybe again an opportunity to remind our audience to put their questions into the text box below the video, and we can get those questions to you. So over to you, Francesca.
Thank you. Thank you, Darren, and it's a real pleasure to share this session with all of you today. So as Darren said, we are going to talk for the next few minutes about a younger patient undergoing TAVI. And this patient, I'm trying to go ahead with my diapo, but I can't control it. So maybe we can just have the next one. Okay, so who is young? So Okay. So if we just consider USA and the European guidelines, so they think the two of them, they're not perfectly aligned. So we can see that we have 65 to 75 years old. So, but I think we all agree to treat a patient and to indicate a TAVI procedure in a patient who is 65 years old. So if we, I can have, okay, thanks. If we have a patient 65 years old treated today, we have to imagine that this patient will live a long life. I think we hope so, but at least 10 years or 20 years more. And so we have to imagine that our patient will maybe experience other events, and also that he will be back to see us for maybe a new TAVI device in a few years. Can we move to Okay, so when we are dealing about a young patient, we do not have only to consider the immediate result, so no paravalvular leak, no pacemaker, a good vascular result, and of course a good gradient for a perfect immediate result. We have to be very exigent with a young patient on our immediate result, but we have also to deal with life expectancy and with long-term results. So thinking to the lifetime management of this patient. Sorry, but my slides are not working, so maybe we can have some help from the central unit. Okay, so go ahead, please. So the pacemaker rate, as we mentioned, is very important. If our patient is 65 years old, we don't want he has a pacemaker after our TAVI implant. We know that some platforms, in particular the classic auto-expandable valve, self-expandable, like the Evolute or the Portico Navitor, are associated with more pacemaker implantation because of a sort of pushing of the device on the conduction system. And we know that the S3 and the arc rate are associated with a really less pacemaker implant rate. So this can be a good option for this kind of patient. And the next, please. Like we just mentioned in the introduction of this session, we do want our hemodynamics immediate result very good. So we would like to have large effective orifice area and a low gradient. And for this reason, a supraannular valve, especially in a patient with a small annuli, and can not only ensure an immediate perfect hemodynamic results, but also to avoid the prothesis patient mismatch, especially in obese patient and especially in patient who have left ventricle ejection fraction slightly decreased at the moment of TAVI, and in which we can allow a better prognosis. The next one, please. And now I wanted just to talk a little bit of the future. So let's take today that this patient will have a long future, we hope. And it is really important to have the coronary access of our cases. And this depends from several anatomic factors on which, of course, we cannot do anything, but we have to consider them with our choice. And this is, of course, concerning the sinotubular junction dimensions and the sinus of Valsalva dimensions, and of course the coronary height. And then we have some devices and procedural characteristics that are, of course, the commissural alignment, and we are going to speak about it in a few seconds, and also the implantation depth and the ceiling skirt height. I think that we all had a period in which, to prevent the implantation of pacemaker, we all tried to implant a little bit higher, but maybe we are all coming a little back on this point, and this because we know that if the patient is young and will have new devices in a few years, we have to preserve the space, and in particularly in the patient that they don't have a very high coronary implant. Next, please. And so the coronary access after TAVI, of course, particularly important. We don't want to have a commissure in face of our coronary ostia, in particular post, because this can can block completely our access to the coronary arteries. So 2 ways to get our arteries access. The one is to use a short frame valve which can stay below the coronary plan, or we have the possibility to orient our device, and this is particularly important because we know that a misalignment can lead to an impossibility to get a coronary coronation. So we could be tempted to take like a solution the small frame valve, because can we have the next slide, please? So we could be tempted to use a small frame valve, but the problem is that this alignment is completely unpredictable with the balloon expandable valve. This can be associated to more aortic regurgitation and to a relative AV gradient increase at 30 days. And the next and the last concept I wanted to share with you is the redo TAVI. Let's consider that our patient might need a new TAVI device in the future. So let's consider 2 important concepts. The new skirt, if we want to do a new TAVI in the first one, let's consider that there will be a tissue which will derive by the interaction of the 2 devices, and this is called the neoskirt, and this high can be modulated with our that implantation. So let's take into account this concept. We can when we choose the first device, and then let's take in mind also that we can have some phenomena of overhang. So this will be maybe more important when we are going to choose the second one than reasoning on the implantation. That's why we have to, I think, to think to the implant depth of the first devices, and considering also, of course, the space we have around the valve, and particularly if the valve touch the plan of the sinotubular junction, we have to consider that we do need space around, and maybe this can be of help on the choice of the first valve and the first VAP implantation. So just to conclude my PowerPoint, I think that we have to optimize the first procedure, looking for a perfect immediate result. With younger patient, we have to really to be very exigent on the immediate result, but also, of course, planning the future, because the first TAVI will be our base for the second one. So let's think to the design, to the implant depth, and the commissural alignment. And just consider also that with the CT scan simulation, we can really choose a tailored approach for our patient and to ease anatomy. And this will be, I think, more and more possible with the new software available, but just looking very carefully to our CT scan. Thank you.
So Francesca, thank you very much for that eloquent presentation and detailing the important aspects. So over to you, Verena. Francesca wants a perfect implant with no pacemaker, no PVL, commissural alignment. She wants great hemodynamics, and she wants you to put it in the right position so she can revalve it in due course. You might, because we know David is going to use an accurate Neo2 in his case, you might tell us how do we achieve those things with the best implantation for a Neo2?
Yeah. So first of all, I'd like to thank you for today's invitation. It's a great pleasure to be part of this session. There we go. These are my disclosures. And shortly about the design features, the Accurate Neo2 is a supraannular self-expandable THV, which consists of an ethanol frame and a pericardial sealing skirt. On top, it has those stabilization arches, which help maintain coaxiality with the native annulus, whilst its open cells facilitate coronary re-access. The upper crown is designed to anchor and capture the native leaflets, while the lower crown shows only minimal protrusion into the LVOT and also very low interference with the conduction system due to the limited radial force. There were There were two new key design features during the evolution from NEO to NEO 2. First, a radio pack marker was added to the delivery system, as you can see it here, to facilitate the initial valve positioning. And second, the so-called active PV sealing skirt was increased by 60% to overcome the initially higher incidence of moderate to severe PVL. Importantly, and contrary to other devices, we don't aim for a high implantation depth using the accurate NEO 2. So the recommended implantation depth is still between 5 and 7 millimeters below the annulus, because the valve experiences its maximal radial force exactly in this range, also to avoid PVL. It is also recommended to use a Safari 2 guide wire, which is available in 3 different curve sizes and allows superior shape retention and an optimized rail support during the whole delivery process. And furthermore, and according to the somehow limited radial force, proper pre-dilatation is mandatory prior to final valve replacement. Another important point is to realize commissural alignment to optimize THV orientation in correspondence with the native valve commissures. And it was shown that this technique is not only helpful to optimize coronary re-access, but has also positive impact on hemodynamics, on paravalvular leakage, and also redo intervention. And this feature is unique using the accurate NEO 2. So to reach commissural alignment, we position the handle with the safety button at 6 o'clock, as you can see it here, so facing down. And this is followed by a directionality assessment in the precast view, having this NEO 2 marker at top of the pigtail, assuming a 1-1-1 configuration of the commissural pulse, and therefore with the native commissures. As example, if we have this one free cell stent strut at the inner curve in the precast view, and this 2-to-1 configuration of the commissural pulse, we can rotate the handle away from the operator, what would be clockwise. And in the other case, as you can see it here, we would do it anti-clockwise. Afterwards, we can check for proper alignment using the cusp overlap view, in which the right and the left coronary cusp are overlapped, and a non-coronary cusp is separated. And in this view, the one free cell should be at the inner curve, and in most cases, the alignment is achieved between half and 1.5 rotations. And then we can release the tension, go back in our free cusp view, and proceed with the accurate NEO 2 implantation steps, finally having this 1-1-1 direction or configuration of the commissural pulse, and 2 wings, so 1 on each side, as you can see it here in the right corner. Continuing with the valve deployment itself. Okay, it's working. We position the bottom of the radio pack marker at the bottom of non-coronary cusp as indicated by the pigtail catheter. And in addition to that, I don't know if you can see it very well, but the upper crown should be located a little bit above the tips of native leaflets. And it is of utmost importance that the final movement in positioning is in a forward motion. Then the first step can be initiated using turning the knob 1 very slowly counterclockwise, which will release the upper crown and the stabilization arches, as you can see it there. And usually there will be some upward movement of the delivery system depending on your degree of aortic valve calcification, tortuosity, LV hypertrophy, and so on. So in this moment, it is very crucial to maintain the position at all costs by slightly increasing the pressure on the delivery system. Then knob 2 can be turned counterclockwise in a very fast way or manner after removing the pigtail catheter, as you can see it here, and also after removing the safety button. And this is the last critical step, which will release the lower crown for full deployment of the valve and should be done under cautious forward pressure. And you will see that the stent holder then drops into the left ventricle. So finally, I like to summarize the most important points to achieve an optimal implantation depth and to avoid any severe micro or macro dislodgements. So do not initially position too high or too low, and always hold or adjust the pressure if necessary. If you're too ventricular, it is necessary to pull the whole system back into the aortic part, also including the stent holder, and to restart again. If you're too aortic, it is completely sufficient to reposition with only small steps forward. Therefore, a good visualization of the analog plane is crucial. Our pigtail should always be at the nadir of the non-coronary cusp. And it is also important to watch our guide wire position continuously. We want to be deep in the left ventricle with the curve of the Safari 2 wire facing upwards. And we want to be at this outer curve position at any cost, because that provides stability and also avoids severe parallax of the delivery system. That said, if we already have severe parallax, it is recommended to remove it prior to full prosthesis release to have a better estimation of the real or true ID, and therefore a cusp overlap view can be especially helpful to resolve this disagreement between the view on the delivery system and the patient anatomy. And even if it is not required, we can also use fast or even rapid pacing to enhance the stability of the prosthesis during valve deployment in case of a challenging anatomy or any unexpected movement. And finally, and we already talked about that, we should always use cautious forward pressure during the final prosthesis release to avoid dislodgement at the end. So thank you very much for your attention.
Thank you, Verena. That's very clear. So I think it's time to get over to David in the cath lab and his team in Brighton, where they're treating this patient. So we've seen the patient characteristics. Francesca has told us what she expects from the case, and David, Verena has taught us how to achieve those that result. So over to you guys, and tell us where you are in the case.
Sussex Cardiac Centre. I'm just going to take you around everyone who's here. So we've got Richard at the back there on the rhythm section, got Jude on X-rays, Alvin is senior nurse at the table, James Coburn and I are going to be doing the case. John is nurse anaesthetist today and is on drugs. Bianca is our chief senior structural heart nurse, and Ted and Alex are preparing the valve. So we have a whole team here. Did I forget anyone?
No, that's everyone.
That's
yep.
incredible.
Well done.
Fine. So we're quite well advanced. We have the ProStar. We noted your little comment about the decade there. That was quite funny. So we have the ProStar in the eye sleeve in. We have everything ready. So Jude, if you could just show us yes. So here's our 3-cusp view. So with the accurate neo, we need a 3-cusp view, we need a 2-cusp view, and then show us the 2-cusp view. The 2-cusp view is a little bit extreme, so we've got a sort of half and half 2-cusp view, but these are the 2 views we're going to use. So I'm just going to put in the Sentinel. James is going to field any of your questions whilst he also helps me put in the Sentinel.
No problem.
So James, tell us first about this device called the ProStar you're using.
Okay, so the ProStar is a way of achieving vascular closure, which is slightly different to the ProGlide. It deploys 4 needles in a 2, 4, 8, and 10, and then you tie the sutures across to each other to effect a meaningful closure. It has a slightly longer learning curve, but it does achieve vascular closure very efficiently, and we've been using it in Brighton ever since we started our structural heart program, and we're big fans of it. But I have to say that we have had to start using ProGlide as well, as a number of the fellows have come wanting to learn more modern techniques at the same time. But actually, it's a very, very good and very, very efficient way of achieving closure in certain scenarios. So now you can just see our technique for putting in the Sentinel. We use essentially a technique whereby we're able to see what we're doing based on the position of 3 wires. We've got from the left radial our secondary access, from the right radial the device itself, and then we have the super stiff wire on the outer curvature of the aorta. So that's quite useful for dictating exactly where you need to be in terms of coming down from the right brachiocephalic trunk and coming up into the carotid artery at the same time. So hopefully you will have seen that.
Okay, so that's in place. ACT is over 250. You see how we had the super stiff wire in an arc there to delineate that we're not involving the Sentinel in that. And now we're going to cross the valve. So I think we'll do this
took
in
about
3-cusp.
15 seconds to put the Sentinel device in. That's pretty impressive. You guys are probably pretty slick with it now in light of the study.
We've done a lot of them, that's true. Can I just see at the top, Jude, just to check we're anterior to the Sentinel? And it's not always really straightforward. Sometimes there's a bit of a curve in the subclavian and that can make it more difficult, but you know, it's a very nice, beautifully designed piece of kit.
I think this landmark technique that we use of using the left radial, right radial, and also the outer curvature makes it easy so you don't have to do an aortic arch angiogram at the same time, which obviously saves on contrast. And so it is quite a useful technique that we've developed locally that we use regularly to help us determine exactly where we need to be.
And David, I take this as an AL1 straight wire standard technique.
Yes. Absolutely, AL1 straight wire. If it doesn't get curled up at all in the subvalvular apparatus, then we'll just switch from here. Just wait for it to blow a few bubbles from the left ventricle, which it often does. Still blowing bubbles. Surprising how often this happens. Okay, now it's stopped blowing bubbles. Okay, so here we have the pressure from the left ventricle. So we'll take our Safari.
Maybe we could show this to the audience because this is quite interesting. As Darren pointed out in the initial slides, the calcium score here was only 600. And so that would be indicative of moderate aortic stenosis at best, but actually the gradient on echo was over 4 meters per second, and there's an evasive gradient of at least 45 to 50 millimeters of mercury.
It's always reassuring to see that, James, isn't it?
100%.
There's something there. So we'll just see if we can get the wire out nice and comfortably. Okay, that's good.
I do think it points out the fact that there is probably pathology in the form of fibrous aortic stenosis that we may have been previously undertreating. And this valve is excellently suited to that kind of anatomy. And so something that we should consider to look out for.
Guys, in this relatively acalcific disease, tell us about your pre-dilatation strategy. Do you stick to the plan? You take the 1 minus the medium diameter of the annulus, or do you do something different?
Yeah, we do the same at the moment. I mean, I think it's probably not quite as necessary, and certainly it's not as resistant. But at the moment, we do exactly the same. Yes.
I think the benefit to pre-dill in this scenario is probably that then you'll reduce your risk of needing to post-dill. So on that basis, if you do stretch the valve appropriately, then that is going to reduce your post-dill rate.
Facing on. Okay, so we've got intermittent capture there. So let's go to maximum output.
So in this scenario, we're using a 20 millimeter sim valve balloon. It's semi-compliant, and we'll just de-air it in the descending aorta just to make sure everything's okay. We just do this very gently and partially just to make sure there's no significant air coming out.
So for the balloon dilatation, I think we'll go 180 at maximum output. I'll tell you when. Okay, so 180 maximum output, pacing on. And keep going, up you go. Okay, and balloon down, pacing off. So in fact, her tolerance of that was pretty good in terms of pressure. We could have gone up to 200 instead, but actually, in this setting, perhaps the importance of the balloon valvuloplasty is slightly less than it is in more calcific aortic stenosis. So we're going to take you through the implantation of the accurate NEO now, hopefully with an eye to coronary commissural alignment.
Okay, we're ready for the valve.
Certainly one of the things that we've learned about this is that commissural alignment is good for coronary access, but what's definitely not good is perfect misalignment. So we'll be trying to demonstrate the alignment of the valve. Okay. So
also,
James,
the benefit to this valve is the fact that if you hold the flush port down at 6 o'clock, there's a good chance in around about 90% of cases that you should achieve commissural alignment without having to make any obvious adjustments to the position of the valve in the ascending aorta.
Okay, so we'll come up and round the top of the arch. As I think Francesca pointed out, this is a slightly horizontal arch, although it's behaving quite well now. So let's stay in our 3-cusp view and just have a look at the baguettes at the top of the...
I think we should come down very slightly.
Top of the valve. Just need to come down a tiny bit so that we can see it. Okay, I mean, it's not so very easy to see, but you can see the 3 baguettes.
So you've got a 2-1.
You have a little flush on the... We got slightly 2-1, yeah. We're going to rotate a little bit.
And David, you don't go to the cusp overlap view to check this finally?
Actually, what we do, partly because in this case, the cusp overlap view is very extreme. So in this case, we're just checking in the 3-cusp view, and then we will switch to the 2. Okay, so that's more of a 3. You see all the 3 sticks are to either side and 1 in the middle. So now we'll come to our two-cusp view.
Looks good.
And with a bit of luck, we should see that this has one baguette on the right-hand side. I'll just come down very slightly.
We got the opposite.
Yeah. So in which case, what we'll do is we'll carry on
rotating round
and just wait. It takes a little while for the system to respond to the rotation. You can see it very slowly swinging round.
And here we come, and you can see the open cell has now moved to the inner curvature, and we've got 2 on the outer and 1 on the inner.
Nearly.
It's very stress-free, isn't it? It's very well tolerated. You're not in any way threatening the patient. It's a really nice technique.
And flush again for us, thanks. I'd just like, if possible, to bring it round a bit more. It doesn't quite want to, but of course, whenever you're doing this, you just have to bear in mind that this is a secondary objective. Just yes, that's great, thank you. Secondary objective, and if we can achieve that, that's all well and good. If it's not swinging round nicely, then we may
try turning it
the other way. You just flush again on the line for us.
Seems to be more responsive now.
Yes.
Yes.
You're nearly there.
There we are. That looks better now.
Okay. So we'll just come down across the valve.
That's looking good now. We're happy with that position. And at this point, we're now looking at where the tantalum marker should be.
Or do you go back?
Yeah, so we'll go back to the 3-cusp view.
And now we're looking at the position of the tantalum marker with respect to the base of the pigtail.
Okay, good. So we're going to do an acquisition here, Jude, 10 at 10. Just give us another flush there, Ted, on the line.
David, one of the things that Verena mentioned to us was that wire forward and that outer curve position. Is that something that you try and achieve in most cases?
Yes, so that's what I meant about this being a secondary objective with the commissural alignment, because of course, with the rotation of the valve, you are interfering ever so slightly with that, and you may choose to decide that that's not something you want to persist with. I think in this position we're pretty good. We've got a very nice really stable position of the valve, so I think we're okay to go. But I think it's a very good point. So James is going to start.
Going to do a shot just to check.
Very slowly undoing number 1 in a second. Okay, so we can go forward a millimeter actually.
Yeah. So as you can see there, the pigtail's not quite
nice and slow
at the base of the sinus. So on that basis, Dave has just pushed the valve very slightly forward. And there you go. You can see the upper crowns just coming out.
Okay, just pause there and we'll do a second acquisition. Okay, I think that looks
pretty good.
Very
so
nice.
we're happy
no
here
evidence
at this
of parallax
point. Everything's
in that
nice and stable. Nothing at the moment. And again, as mentioned, we do this incredibly slowly. There's no point in rushing at this point. Fine adjustments can be made right to the end of travel with anti-clockwise rotation of handle 1. So that's looking really good.
Okay, so again, we will check that when we've hit the hard stop.
And that's the hard stop on end of travel.
So let's just have a look and see how that is sitting. Yeah, I mean, some millimeter higher than perhaps is ideal, but I think that's fine. So we're going to deploy that now.
Okay, so we're going to now turn handle 2 clockwise, anti-clockwise as fast as we can. Perfect.
Nice.
Okay.
Beautiful.
Good. Okay, so now we're going to very slowly remove the
So you can just see there that by pulling on the wire, we've pulled the delivery system into the middle of the valve. And we do this incredibly carefully by a combination of slight pull, but also push with the wire at the same time to change the angles to help bring the nose cone again can see there just into the middle, but at the same time, so that we can get a good assessment of aortic regurgitation, if there is any at the end, we tend to leave the wire in so we can put a pigtail in to measure hemodynamics. And we just do this very, very slowly. There we go. And we're happy with that. And at this point, you reverse your handles. So you close two, first of all, which brings the nose cone in, and then you close one.
Should take the pigtail. Great.
And then that means that the capsule's closed and we can safely withdraw the delivery system.
Yeah, and then we'll put our pigtail in over the Safari, take the Safari out so that we then don't have a stiff wire keeping the valve leaflets open. That helps us assess the AR most effectively in a setting where we can still pass the wire if we wish to. So we'll do a
Beautiful job, guys, so far.
Here.
David, you keep the wire in place because it's a
Yes.
little challenging sometimes, this system, to get through those open arches in due course.
Exactly. So especially if you did decide that you want to post-dilate, what you don't want to find is that you've crossed inside the arches. So because then, of course, you could, if you were injudicious, move the valve by pulling on your balloon. So you just have to be rather careful of that. So we know we're central here. We can't be anywhere else. So we will leave that pigtail in position.
And then we should have hemodynamics for you as well.
Final shot.
Yeah.
You'll notice as well that we leave the pigtail right down in the root. I think it's very helpful if you're not routinely doing echocardiography as your main way of assessing the AR, is to have the pigtail right down there so that you can really see the density of contrast in the aorta and the density of contrast in the ventricle. So we'll test that now. Okay, so there is a little bit there. We will probably choose to post-dilate that, I think. We may do
unusual
one,
with this valve to have that much, so
yes,
perhaps a post-dill would be
so.
appropriate. Yeah.
Yes.
While you're getting that ready, David, also interesting to
so.
notice that in this three-cusp view, you've got perfect commissural alignment. You've got a 1-1-1 configuration where they should be. So
yes,
your secondary objective has been met. Francesca will be happy.
Yes. Some of that, of course, might be the pigtail, but it has no wire in it. So I think we will simply plan to post-dilate.
We'll screen at 200.
With our
pace at 200.
With our
David, I wonder what this looks like in the partial cusp overlap view. Is it somewhat constrained in that RAO-caudal?
Yes, it will be. Yes, so if we come due to RAO-caudal more, you'll probably see it's very slightly elliptical. Yes. I mean, the annulus in this case, of course, is a little bit elliptical, but even so, in this view, it will. Oh, well, actually, it doesn't look too bad as it happens. Yeah. Looks quite nice.
Nice for you to do the post-dilatation then.
Sure. I mean, I think we can show you how to do this very safely by using this technique. And if you do have to do it, which we have to say with a small and medium valve, we're doing probably no more than 10% of the time now. But if you do, this technique enables it to be done very safely.
Okay, so key to this, of course, now is to pace fast to get the pressure down to below 60. So we're going to try that. We're going to try pacing at 200 beats a minute, a maximum output, just to see if we get the pressure down adequately. So 200 maximum output pacing on. Pacing off. Thank you. We'll come to the three-cusp view, I think. You've taken all the RAO off. Okay, fine. Thank you very much. We'll go a little bit faster than that then, 220. Because we want to see the pressure down at 60. So 220 maximum output pacing on.
And that's fatiguing nicely below 60. So up we go. And you can see some further expansion
pacing
of this.
Off.
Quite nicely there.
You're very
Okay,
gentle
nice.
with your balloon,
So
gentlemen.
Just scream for me. That's good. Should we take the hold on? Are we confident?
Yeah, I think, okay, let's do that. James is confident that this will be fine. I mean, I must say I'm a little surprised there was any. And if anything, we probably were just dealing with a tiny bit of elliptical expansion of the valve, probably. So I think this balloon will have done it, but let's have a look. James is confident, so we've taken the wire out. So Jude, let's go to where the base of the valve is coaxial with our orientation. So that'll be slightly, yes, okay, either slightly more caudal or slightly more LAO. Yeah, that looks nice.
Looks
okay,
very good.
This is good. Symmetis height. Okay. Okay, yes, that's very much better, isn't it? It's. I think it's just a tiny bit of elliptical expansion of the valve has been corrected. So I think that looks very good.
Yeah.
Hopefully that will stand her in very good stead for many years now.
It looks perfect, guys. So what we've, if I can bring in Francesca. So Francesca, are you happy with this result that the guys have achieved? Does it tick the boxes? What do you think in terms of coronary access here, or re-access?
Oh, I think we are quite well. Congratulations, Dave and James. Thanks for the nice demonstration and the good result.
We'll take the brain out now.
Yeah, so we'll take out this cerebral embolic protection. We'll check the filters and see if there's anything there out of interest. We'll then, using a wire, take out the pigtail, and to make Darren happy, we'll show you the closure with the old style ProStar at the same time. And hopefully we can demonstrate
Sorry,
that.
Jude, if we just come back to the heart,
yeah,
we'll take the pigtail.
Sounds great, Dave. David, when you're ready, could I ask you to put up that final shot again? Because I think it's very interesting to look at this valve in the context of a potential revalving procedure. So we know that the leaflets on the NEO,
angiogram.
the leaflets on the NEO do not extend outside of the commissural post. So if we look at the left main there, if we put another valve inside this, you still have that gap between the commissural post and the wall of the aorta. So not only do we have perfect coronary or commissural alignment, coronary access, but this is an easy revalve for this particular patient. So it's again demonstrating the importance of lifetime management and the ability to achieve all these things at the index procedure.
Yeah, no, I agree with you. And I think, the Accurate Neo has come into its own a little bit with the advent of this concept of putting patients in who are younger, because both at the index procedure and indeed for valve-in-valve TAVI, it certainly has some advantages. Should we go up to the brain, Jude, to take out the brain? Okay, push this down.
Darren, have we got time to show you the leg closure at the same time?
Okay,
I think that you guys can do it, given that you've got about 60 seconds, but of course.
You'll enjoy this bit, Darren, because you'll remember the archaic knot creation. Should we have the light on? So James and I will demonstrate the making of the knot. Thank you. Thank you. Hang on to that one.
Sure.
And guys, the dilator for this is an expandable sheet. Do you place the dilator back in?
Exactly right. Yes, we do. We put it in 2/3. We apply a little bit of proximal pressure, and then we leave a safety wire in at the same time, just to make sure all is well.
Okay,
a little bit of pressure, man. All right.
Is going to take the sheath out. That's good. Keep going.
And much like the ProGlide, it comes with a pusher. So if the sutures are having difficulty coming down, then you can just run them down with the pusher.
The pusher. Thank you. Oops.
So here we go. down goes the pusher on top of the arteriotomy. And hopefully you can see now that there's pretty good closure of the leg. And then the second blue suture goes down. About 60% of the closure comes from the white suture, and then about 40% from that. So we'll just take that out gently. And there we are.
Guys, that's a beautiful demonstration of the self-expanding system yielding an excellent result. So from Francesca, Verena, myself, congratulations on a wonderful case, and thank you for showing this the procedural steps so clearly to us.
Thank you very much. Thank you.
Pleasure. Thank you for having us.
And so to wrap up this session, I think we've had an enjoyable hour where we've discussed first with Francesca the expectations of contemporary TAVI in younger patients, that an excellent index procedural result is expected, but also leaving behind good hemodynamics, good coronary access, no pacemaker, and the opportunity to revalve in due course. I think that we saw very clearly the steps of the procedure that were outlined by Verena, and David and James illustrated those to us. We saw a really nice live case and hopefully a fantastic result for the patient. So with that, I'd like to close this session. Thank you for your attendance. I hope you've enjoyed it and learned from the session. Francesca, Verena, and David, on behalf of TIO, thank you for your contributions, and we hope that you stay tuned for the next plenary sessions that are going to be on revalving in TAVI. So thank you for your attention and enjoy the rest of the course.